as you've also heard this morning, though it's been law for a couple of years, there are many elements of this law that most people and many physicians don't know about, and don't know about the impact that it's had on patients and doctors in the country. And because many of the elements of the ACA have not yet gone into effect, many don't know the expected impact of the law over the next several years. As you heard from Vivek this morning, many challenges lay ahead with regards to the ACA, especially with regard to educating other physicians and the public in general, and helping to dispel some of the myths about the ACA. So this morning we have 4 great speakers providing 4 different expert perspectives who will help us understand some of the impact of the ACA and some of the challenges that lie ahead, and in particular how members of Doctors for America can help with these challenges. So what we're going to do is we'll have each of them speak for about 5 to 7 minutes or so, and then we will open it up for questions, and we'd like this to be an interactive session. So I will introduce them. Their full bios are in the program, but I'll briefly introduce them one at a time. So we'll start with Harold Pollack. So Harold is the Helen Ross Professor at the School of Social Service Administration and the Faculty Chair of the Center for Health Administration Studies at the University of Chicago. He's a former board member of Doctors for America, and he serves as an advisor to DFA, and he currently runs the DFA policy calls, which some of you have probably been on. He's published widely at the interface between poverty policy and public health. His recent research concerns HIV and hepatitis prevention efforts for injection drug users, drug abuse and dependence among welfare recipients, and pregnant women, infant mortality prevention, and child health. Harold.
Thanks a lot. Can you hear me? Is the mic? Can you folks hear me in the back? Okay, so I wish my mom could afford that introduction.
Move the mic closer.
I'll just go up close. You can come here. I just said I wish my mom could have heard that introduction. She would have enjoyed it. She loves the Helen Ross Professor bit. So this is Darwinian competition among the moms of many of us here. I should tell you, I am an actual rocket scientist. That's left off of my bio. I designed rockets at Draco Labs at MIT, so I feel very well equipped, although less well equipped, as he says, doesn't matter. I think during the question and answer we'll get into some of the mechanics of ACA. I actually want to, I'm looking forward to the nuts and bolts conversation. I actually want to bring us back for a moment to the moral dimension of what brings us here as well, because ACA is important because it's improving the proficiency of American medical care, but it's also important because of what it says about our need to take care of each other and to protect all of us from risks that would crush any one of us if we have to face those risks alone. And in the kind of work that I do, that social insurance commitment that we make is really core to what health reform is about. And it's very complicated in the same way your car is really complicated if you try to open up the engine and figure out how all the pieces work. But what it's trying to do is very important, and at some basic level is actually pretty simple. I'm going to start with a little bit of a tangent, which I hope will be relevant before 7 minutes goes by. As I mentioned, I have an amateur's interest in physics, and I'm a rocket scientist. And it turns out that 2 weeks ago, a great Chinese physicist named Fowler passed away. And according to The Economist's fantastic obituary, he got himself in trouble. And he got himself in trouble originally in China because he wrote a paper that was called, with a controversial title, A Solution of the Cosmological Equations in Scalar Tensor Theory with Mass and Black Body Radiation. Apparently the Chinese government could not abide by that revolutionary tract, which they called capitalist metaphysics. And apparently the Big Bang Theory is contrary to Maoist ideology in some way. And at one level, the apparatchiks in China rightly feared that the democratic potential and intellectual authority of scientific inquiry, their claims of unique insight in this area just could not hold up. And at another level, the independence that this person showed by writing that paper, knowing that it was illegal to do tensor calculus, apparently, was something that they disliked. I actually feel a connection to him, not because I'm a physicist of that caliber, but because he was sent to a coal mine, and he was sent carrying one book, Classical Field Theory by Landau and Lipschitz. And I know that book. I actually worked on that book. I broke my pencil on it 25 years ago. It's a very hard book. And I found out about that book because a very wonderful elderly man named Abraham Page, who comes to the Princeton Library where I worked behind the desk, and he used to talk about that. He used to talk about it with me. He actually he wrote his doctoral dissertation while he was hiding in an attic from Hitler in Amsterdam, not unlike Anne Frank. It's pretty humbling, by the way, for those of us who head tripped over our dissertations that we accomplished this. And I think, last week was Holocaust Remembrance Day, and Marshall Gantz mentioned his connection to the Holocaust yesterday. And I think about it as well. And I think it's not coincidence that a lot of Jewish doctors during Freedom Summer in Mississippi went down and tried to help to correct injustice. Many of us in this room have probably heard Jack Geiger describe how he went down to the Mississippi Delta and began prescribing food to malnutrition, to children who were malnourished. And when people complained about it, he opened up his internal medicine manual and he said, well, it says right here that prescribed therapy is food when someone is malnourished. And, access, how do we honor some of the people who really sacrificed a lot, not just being sent to coal mines for their scientific integrity, but people who survived a lot. And I think it's that we, in our own lives, we share that commitment to scientific inquiry and to human rights. And access to affordable health care is a fundamental right. And I think we can't move away from that as we explain to people why health reform is important. On the campaign trail, many of us met people who were medically bankrupt, who were medically uninsurable, or who were very sick and were being really faced with punishing deductibles and co-payments that they couldn't pay. I take care of a mentally disabled man, my brother-in-law, and I'm very fortunate that I have a nice job. We're very grateful for the Medicaid program because even in our situation, we get a stream of six-figure medical bills that Medicaid helps to pay that we could never pay ourselves. And I think we have to remember these programs don't exist for some group of other people that we should be nice to people who need help. It's all of us in this room are one slip away from needing some very serious help. And health reform, the Affordable Care Act, imperfect as it is, and complicated as it is, has already made the healthcare system more decent and humane for people. Removing lifetime caps on insurance benefits for people with really serious injuries and illness. That's really important. 2.5 million young adults are insured now who would otherwise be uninsured. A lot of those people are actually people with chronic illnesses who, because they can go on their parents' health insurance, have a way to take care of their asthma or their autism or whatever the issue is in a way that they could not by themselves. When we think about the alternatives to health reform, when I hear about the repeal and replace option, we don't exactly know what that is, but when I've dug around and talked to critics of health reform about what it is, what it really amounts to is tens of millions of people will lose health insurance coverage that right now they're entitled to under law. And there's a sense of political urgency in the repeal effort. And when I talk to people about it, I talked to former Bush official James Capretta, who's a very nice person. I enjoyed talking to him. And he basically said, once the money starts to flow, you can never stop this thing. And that was it. And he had a sense of urgency about the repeal effort. And I think we have to have the same kind of urgency in making sure that we protect universal health care. Health reform raises many complex delivery issues. We'll get into those. But I think there's one inescapable issue that's not technical, it's not political, it's not ideological, which is that we're spending, if Zeke is to believe, $2.8 trillion this year on health care. We have to treat people decently. We're spending, if we're the 5th largest economy in the world in the healthcare sector, we can do that. And so I'll just mention one more thing about my brother-in-law, and then I'll sit down. I haven't used up about 3 hours, I'm sorry. But when I think about the repeal and replace effort, it won't affect my family, and it won't affect my brother-in-law, who, because he has a disability, would be protected. It really would affect, though, the men and women who take care of him, the direct care workers. These are people who earn on average around the country about $11.24 an hour. About a third of these people themselves are uninsured. This is the working poor. And these are the people that we trust to calm our relatives when they get anxious, to clean their soiled linens, to do everything that needs to be done when we're not there to look and make sure that it's done. And someday those will be the people taking care of us. And those are the people that really need us to stand up for them. And there's a face of the working poor in America that we don't often think about. Congressman Paul Ryan recently said, "We don't want to turn the safety net into a hammock that lulls able-bodied people to lives of dependency and complacency that drains them of their will and incentive to make the most of their lives." That's not the face of people that I see when I think of the men and women that really are taking the hardest jobs in America and often getting the lowest pay. So we need to, I think we can be very proud of health reform, that we're helping those people, we're helping to make sure that people who get cancer are less likely to lose their home, and that families don't face the kind of crushing problems that people have when they're uninsured or discover that their health insurance doesn't work when they get a serious illness. So alongside the complexities of the delivery system, I just want to be straight up raising the moral question, because I think that's a big reason why many of us are here in this room. Thank you.
Thanks, Harold. Our next speaker will be John Desser. So John is Vice President for Public Policy and Government Affairs at eHealth. Previously, Mr. Desser served as Deputy Assistant Secretary for Health Policy in the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. He was also a health policy advisor to John McCain's presidential campaigns in 2000 and 2008. While at HHS, Mr. Desser was selected to lead the administration's Affordable Choices Initiative, which was designed to extend basic, affordable health insurance coverage to the uninsured.
Thank you, Michael. It's a great pleasure to be with all of you this morning, and I'm really thankful for your leadership and commitment to the things that we've been talking about this morning. My father is a retired rheumatologist and internist, and I think you'd be really excited about your efforts. I thought what Dr. Emanuel shared this morning was fascinating. The history of health reform, going back to Teddy Roosevelt and FDR. I just really appreciated that. And also your passionate remarks about the importance of this law. I've worked on the issue of the uninsured for about 20 years, which is not nearly as long as the entire debate has gone on, as he pointed out. But the important thing that I think we should take a moment and step back and look at is the fact that we do now have a law, and that is hugely significant. Yes, there's still controversy, and Dr. Pollack mentioned repeal and replace. I think historians will argue for decades about whether some of that controversy could have been avoided if the bill had passed with 70 votes instead of 60, or whether there would be as much energy on the part of people attacking the legislation in the courts if that had happened. As Liz just said under her breath, that may not have been possible. And I think a lot of people have that viewpoint, and it's a legitimate viewpoint. Would it have been possible to have more Republican support for this law? I don't know the answer to that, but I do know that we have a law in place. And to the chagrin of probably some of my friends, the rhetoric about a government takeover of healthcare is just not factual. That's not what this law does. Now, that may be disappointing to some in the room, I understand that. But it's good rhetoric, but it's not factual. Let me tell you a little bit about the company I work for now, eHealth Insurance. we're at ehealth.com. If you're ever talking to someone who doesn't have health insurance and is looking for it, you can find it on the internet. This company was founded by a good friend of mine who was doing very well in the mid-90s, the internet boom in Silicon Valley, and he had a pressing desire to find a way to use the internet to help the poor and the disenfranchised. And he was dreaming for months about how one could accomplish that. And he met with the founder of Netscape, and they talked about this for a long time. And finally, after a lot of research, he came back and he said, I've got it. It's the individual health insurance market. And Jim Clark said, what is that? And Vip said, exactly. If you don't get your insurance through your employer, you have no idea where to go, what to do, how to look for insurance. You maybe call your car insurance broker and ask them if they do health also. And you have no idea if you're getting a good deal. You have no idea what the other options are. So we saw that dysfunction, the lack of information, the lack of transparency in the individual market, and we thought that could be a place where the internet maybe could make a difference. The uninsured has always been a focus of our company because so many people don't know what their options are, and we thought the internet would help with that. From the beginning, we've always supported guaranteed issue, a mandate, tax subsidies for lower income people, which are all present in this legislation. And the mandate has gone up and down in terms of its popularity, but it's something that our company has supported. 13 years later after its founding, we are now the #1 source for health insurance for individuals, families, and small businesses across the country. We are in all 50 states and DC, and we offer about 13,000 different products from about 250 different insurance companies, all available with the best state-of-the-art technology to learn about the coverage, find out if their doctor is in the network, and make apples-to-apples comparisons about their health insurance products. By the way, on that middle point, we have found, shockingly, that people really don't have a lot of loyalty to their health insurance carrier. But they have a lot of loyalty to their physician. They want to know if their physician is in the network. That's almost important to them as premium price. So we invented technology that allows you to put in your physician's name, and we'll pull up all the plans that work with that physician. The Massachusetts Connector thought that was a good idea after being up and running for several years, and hired us to provide that technology to them, which we are now doing. So through all this and mastering the process of driving internet traffic, we've now covered more than 2 million people, 40% of whom were previously uninsured. And if this discussion is about the challenge of ACA implementation, I would submit to you that the challenge of ACA implementation is meeting the promise of covering potentially 32 million, or Zeke used the number 50, I think that depends on over what length of time you're uninsured, but in any case, millions, tens of millions of uninsured Americans. And that, I think, is in large part how this act is going to be measured by voters and by the media. So after 13 years of this and tens of millions of visitors to our website, we've learned a little bit about how to attract people to it, how to encourage consumers to give them the information they feel they need to make an informed decision, and to enroll in coverage using the internet. In their wisdom, in my opinion, HHS has recently issued regulations covering a whole variety of issues in implementation of the exchanges. But one of them allows two things that are important to my little company. One is we can license our technology to states who wish to rent it instead of invent it. So we can help states who want to borrow our technology, and we can make that available at an affordable rate because we're not reinventing it. We can just license it. But secondly, for those who qualify for premium tax credits, the tax subsidies, people who earn less than 400% of poverty, recent regulations clarify that we can work as an independent conduit, online conduit, with an agreement with the state exchange to provide all the people who come to our site access to the same plans that are available on the state exchange. We really believe that's going to be a big part of meeting this promise of covering 32 million uninsured Americans. And I think that was a thoughtful and important decision. So the upshot of all this, from my perspective, is there are many other aspects of this act that are very important. The quality improvements, the changes to Medicare. You've heard about some of them, and you'll hear more about the others. But I think in the simple voter's mind, in the mind of sort of your average layperson, the question is going to be, did it meet the objective of universal coverage? Did it cover people? Did people get enrolled? S-CHIP is a great program, but we still have too many kids who are eligible for S-CHIP and Medicaid who aren't enrolled in it. And I think this administration is taking a thoughtful approach to that question. And I think with your efforts, we have a chance to be successful here.
Thanks. Our next speaker will be Elizabeth Fowler. So Liz serves as Special Assistant to the President for Healthcare and Economic Policy at the National Economic Council. She joined the NEC after serving as the Deputy Director for Policy for the Center for Consumer Information and Insurance Oversight at the U.S. Department of Health and Human Services. And this is the new agency tasked with implementing the insurance market reforms included in the ACA. During the health reform debate, she served as Senior Counsel to the Chair and Chief Health Counsel to the Senate Finance Committee Chairman, Senator Max Baucus, where she played a critical role in development of the committee and Senate health reform legislation. Yes, thanks.
Thank you very much. I really appreciate being here, and I want to echo sentiments about how important your support was for health reform. It really was very critical. And what Zeke said about how Congress listens to what people are saying is absolutely true. Every day during health reform, we got an update about who was calling in, who was in favor, who was against, who was for, who was not quite sure, and a pretty detailed report of all the calls coming in, all the letters, all the emails. So if anyone ever tries to tell you otherwise, don't let them, because we really do, on the Hill, speaking with my old hat on, pay a lot of attention to that, and your support, your calls was really critical. I won't give you any advice about what specialty to go into, nor will I tell you where to invest your money in the healthcare sector. First of all, I'm not allowed to invest anything, so my money sits in probably some dead mutual funds where they'll be, because I have to file a financial disclosure report and I don't know what I'm doing anyways. But anyways, I do want to say before I give my remarks that we actually did try quite hard to get Republicans on board. Many hours. My boss is a moderate and felt like it was important to have Republican support for healthcare reform in order to make a more lasting law that we and protected from what we see is constant sniping and opposition. We were unsuccessful, and I think for political reasons. But we spent many hours in a small room with a lot of Republicans trying to get their support, and I think at the end of the day, they decided it was better to oppose and fight it than to try to go along. And it was unfortunate, but that's where we are today. So I wanted to just spend a little bit of time talking about some of the highlights from implementation, what we've achieved so far, and then also what we have coming up are some pretty big challenges. And when the law is fully phased in, starting in 2014 and beyond, I think we will see a much more fair system where 33 million people are able to access coverage. We won't get to 100% coverage, but we'll get into the mid-90s, which I think is a heck of a lot better than we are today. And we'll have the opportunity to buy coverage in a market that doesn't discriminate against patients with a pre-existing condition. Until then, and even over the last 2 years, we've done quite a bit to provide coverage and stabilize existing coverage. I want to highlight a couple of those areas, and then also recent efforts to make the health insurance system more fair, and then delivery system reform, where I won't spend too much time because I see Rahul Rajkumar from HHS, who is with the Healthcare Innovation Center, and he's going to talk more about that, so I don't want to go into too much and steal his thunder. So in the last 2 years, as Harold mentioned, we've covered 2.5 million young adults who can now stay on their parents' policy. We know that those kids are, those young adults are staying on their parents' plan in private coverage. This isn't a result of the Medicaid expansions. and it's specific to that population, so we know that it's a direct result of the law. Free preventive services, we know that 54 million people with private coverage now have access to preventive services and wellness visits without cost sharing, which they didn't have before. The pre-existing condition insurance program, which provides coverage, it's a temporary program for people who've been uninsured for 6 months and have a pre-existing condition. We have over 50,000 people enrolled. If you've seen the most recent HHS report, you'll know that this program is covering extremely sick people. The average cost per person in that program is $28,000 a year, and that's because we're finding that the rate of people with cancer, the rate of people in need of transplants, just very sick people who are really unable to get coverage in our broken system today. And I think that's a testament to the real need out there, as John indicated, and how broken our system is. The early retiree insurance program, this is for to provide subsidies for employers to maintain retiree coverage. Over 6,600 employers, including state and local governments and organizations, are enrolled to get subsidies to provide the coverage. This is for people who are 55 and older but aren't eligible for Medicare. If their retiree coverage wasn't there, most likely they'd have a hard time buying it in the individual market. And then new benefits and savings in Medicare. In 2011, if you've seen the reports that came out right around the 2-year anniversary of the ACA, 3.6 million seniors got coverage for their drugs in the donut hole, in the Medicare drug donut hole, with an average discount of over $600 that amounted to total savings of $2.1 billion. This is people who would have been paying 100% of the cost and now get a 50% discount, and that discount is increasing over time, and it will cover the whole donut hole by 2019. 32.5 million seniors received a free preventive service or a free wellness visit last year. Those were services that either had a cost sharing or actually Medicare didn't cover an annual wellness visit, but this is to give people a chance to get a real checkup each year and a real chance to get the tests that they need to stay healthy and prevent illness further as they age. Between 2010 and 2012, Medicare Advantage premiums decreased by 16%, while enrollment increased by 17%. And there's a new report out today that's about how some of the bonus money for these private plans in Medicare has been misspent. But I'll tell you, even saving dollars, we know that those plans were overpaid by about $200 billion. That's about how much has been cut under the ACA, but nonetheless, we're seeing enrollment increase while premiums have decreased. And over the next decade, because of the savings in Medicare, the average senior will save $4,200 on premiums and on Part B cost sharing because of the ACA, and that's thanks to health reform. In terms of the down payment we're making on insurance market reforms, of course, the big changes take place in 2014, but in the meantime, we have some pieces, and John and others mentioned them, no more lifetime dollar limits on coverage. So people who are really sick, you can't say after $1 million we stop covering you, or after $2 million, those annual limits, dollar limits are now prohibited. Annual limits are restricted, and they're phasing up until 2014 when they're going to be prohibited altogether. Children with pre-existing conditions, we couldn't get rid of pre-existing conditions for everybody, but we did it for children starting last year. 17.6 million children now can't be denied because of a pre-existing health condition. That's a really big change for a lot of children trying to buy coverage. Rescissions, your health insurance company can't turn you down or try to rescind your coverage by saying, oh, you made a mistake when you were filling out your application. Starting in September 2010, rescissions were prohibited as well. Appeals. Many Americans now have appeals rights, the ability to appeal health plan decisions if they disagree and they felt that the service should have been covered. That is a new patient bill of rights that's now taken effect. And then starting this fall, what we call the plain language requirement, and a lot of people haven't really paid a lot of attention to this provision, but starting this fall, health plans are going to have to start using the same definitions for the same health insurance term. So when they start saying deductible, co-insurance, cost sharing, they all have to use the same definition, and they have to explain it very clearly. Health plans are going to be required to provide consistent and comparable summary of benefits and coverage information. So if you're trying to decide whether you should be on your your spouse's policy or your policy, you'll actually be able to look at the material and decide which one is better for you and your family, because the information that's going to be presented is going to be presented in the same way across the board. The medical loss ratio, 76 million Americans are enrolled in a health plan that now has to abide by the 80-20 rule. The 80-20 rule says, and this is the medical loss ratio, it requires plans to spend 80% at least of every premium dollar on medical costs or quality improvement activities rather than administrative costs and profits. That started last year. And if they don't meet those standards, they have to give rebates. They have to refund your money back. The first rebates are going to go out later this summer, so we'll see exactly who's made the cut and who's going to have to give back rebates. And then premium rate review. For the first time ever, in every state, insurance companies have to publicly justify rate increases above 10%. If rates are going up more than 10%, they have to explain why. In some cases, they're justified. That's what the underlying medical trend is. But nobody's ever looked behind some of these numbers. Some of the states, I worked for the senator from Montana, some states have a requirement that health insurance companies actually have to file the rates. Some of them have to be pre-approved. In Montana, you didn't even have to file your rates. A health insurance company could just impose the rate increase. Nobody looked behind the numbers. Nobody even looked at it. Now in every state, they actually have to look behind if a rate increase is more than 10%. I mentioned delivery system reform, and I don't want to go too much into this because I think other speakers will touch on this. But accountable care organizations, we know that 32 leading organizations are participating in the Pioneer model. They're transforming their practices in a way to emphasize prevention and care coordination and better ways of providing more efficient care. HHS estimates these efforts are going to improve care for 800,000 Medicare beneficiaries and save up to $1.1 billion over the next 5 years. And then earlier this month, we announced that 27 organizations signed on for a different version of the ACOs. Those who are part of the program represent every kind of health organization you could imagine across the spectrum. And we've already received another 150 applications for a July start date. So we're very enthusiastic about some of these changes. Partnership for Patients is another example. This is a voluntary program with no incentive payments. And this just says we're going to sign up organizations to participate, and they have to pledge to reduce preventable injuries in hospitals by up to 40% and preventable hospital readmissions by 20% by the end of next year. So again, it's voluntary, there's no payment incentives, and even then we have 2/3 of American hospitals signed up for that program. Over 4,000 have signed up to reduce medical errors, and more than 4,000 additional partners from employers to health insurers. So I think that's a testament to the level of excitement and enthusiasm out there. Really are seeing a national dialogue about trying to change the way that healthcare is delivered in this country. So a lot of that I think is due to the ACA, but a lot of that is just having sparked the conversation, and these are efforts that the private sector has wanted to pursue for years but didn't have the market share. They wanted Medicare to lead the way. The ACA has really put those tools in place in Medicare, and Medicare is doing its job. In terms of next steps, we're working to implement the exchanges. This is, if you're talking about big challenges, this is probably the biggest challenge in health reform, is making sure that the exchanges are up and running by 2014. 33 states plus the District of Columbia are receiving now establishment grants to set up exchanges. We put out rules to establish for what exactly states need to do to set up exchanges and what health insurers need to do to participate in the exchanges, and for small businesses to participate in the small business group health options. We put out rules for what we call the risk mitigation strategies. I won't go into detail because that's kind of not the most interesting aspect, but important. And then essential health benefits. We've explained our intent to how we're thinking about the regulations around essential health benefits, and we can talk about that further. But it's going to be a struggle. We have a lot of governors who are sort of sitting on their hands, and they've decided they're going to wait and see what the Supreme Court says, and they're going to wait and see what happens in the election. And just this morning there was an article in Politico about whether or not states were going to come back in a special session later this year if everything goes in our favor, and try to quickly set up an exchange. It's going to be really hard for those states to get everything up and running by the time that they have to be certified to participate. I can tell you HHS doesn't want to be running any state exchanges. We really want states to be doing this on their own. But I think making sure that we can give the resources that we need for states to do their job is one of the challenges. Other challenges we face, besides the tight time frame, limited funding for implementation. $1 billion was set aside in the law to implement the law. If you think about it, that seems like a lot of money, but let me give you a comparison. In 2003, the Medicare drug bill included $1.5 billion for implementation. That was one benefit for one population, for one program, and it was 50% more in funding to set the whole program up. So the agencies are cash-strapped. They're doing everything they can. They will meet their deadlines. No doubt about that, but with fewer resources than would be, I think, ideal. Public education, it's clear that the public doesn't understand the law, and I think this is where we really count on a lot of our outside groups like you to help, and people really do listen to their doctors, and they really do care what their doctors say. They, to some degree, care what we say, but they really care more what you say, to be quite frank. But it's really hard to explain what's in the law when we're faced with every day a new report coming out that's full of misinformation and really trying to gin up opposition for the law. And implementation and getting the word out in that environment is more challenging than you might imagine. It turns out, if you look at the polling data, if you ask everybody about each individual provision in the bill, they actually support it, except for maybe the mandate. That one doesn't hold so well, actually, but well, when you ask the poll and how you ask it. But by and large, a vast majority of people believe that health insurance companies should have to take people who come to their door, believe that you shouldn't discriminate against people with pre-existing conditions, believe that you ought to make coverage more affordable through Medicaid or through tax credits that offset the cost of coverage, that kids under 26 ought to be covered on their parents' plans, that prevention and wellness ought to be part of every health plan's benefit package, and that quality ought to improve. So everybody, I think, agrees on the pieces of it, but when you get down to it and package them as a whole, they still see it as a negative, or at least about half of the people do. So the core challenges I mentioned are obviously a challenge. We are confident we're going to win, but that's about all I'm going to say, because I can't possibly speculate on what the Supreme Court will do, nor should I do that. I don't want to get in any trouble. But we're pressing full steam ahead, and we are not waiting to see. We don't have enough time to wait and see, so we are moving forward with everything we need to do to get the law in place. I'll just close by saying that I'm really proud of what we've accomplished over the last 2 years and everything that is to come. When fully implemented, the Affordable Care Act will bring down costs, will improve care that's provided in this country, and cover over 30 million Americans who would otherwise be uninsured. I think that's a huge historic achievement, and want to thank you all again for all of your help in making that happen.
Thanks, Liz, for that great summary. Absolutely. So our fourth speaker is Jack Lewin. So Dr. Jack Lewin was CEO of the American College of Cardiology for the past 6 years and CEO of the California Medical Association for 10 years, where he represented the medical profession, patients, and advocated for healthcare reform. Before that, he was Director of Health for the state of Hawaii for 8 years, where he helped implement Hawaii's universal employer mandate coverage law and created parallel public-private insurance coverage plan for self-employed and part-time employed persons, students, and other uninsured individuals. He has practiced internal medicine and primary care in Hawaii, California, and Arizona. Jack, thanks for joining us.
I feel just more relaxed talking, standing up, actually. You know, it really is exciting to be in this audience. I'm empowered by just being here, because it just feels terrific. And one of the exciting things for me about sort of taking a sabbatical after, you know, kind of just working non-stop for so many years, is to have the rest of this year just to do what I think is right in these regards, and to help in any way I can. So it's incredibly exciting, given how many vantage points I've been fortunate to have in my career, as a physician looking at healthcare from so many places, starting insurance products, running a hospital system, being a doc in both a small practice and a group practice, public health vantage point, and then working with the profession. Harold, I really appreciated your moral challenge. John, I think you're right. It's about coverage, and there are ways to get there. And Liz, that was a fantastic summary of where we are, and your heroic actions and hard work in the middle of it are just been tremendous. You know, my prediction is that the Supremes, if they actually did, one out of the 5 conservative justices is going to have to look at this and see if they actually threw this law out. They would upset so many precedent decisions. There'd be so many lawsuits, so many, pre-decisions that would be cast. So I think at least one of them is going to see the light, and I certainly hope so. But you know what? What if there was no Affordable Care Act? It's a terrific thing that we have it. But what if there was none? I'll tell you what, as you all know, the bullish forces out there that we all face, that the nation faces, that the patients face, that the profession faces, things like the runaway costs. We've done all these wonderful things, but we find that what we're doing now is unaffordable to individuals, families, businesses, state governments, federal government. The need to integrate, consolidate, to be more efficient is a bullish force. The need to fix the unevenness of quality is a bullish force that has to be addressed. Fee-for-service as a dysfunctional set of incentives and payment has to be replaced. We need payment reform. Coordination of care is clearly an area where we have a huge need to move toward team practice and new models and all of that. Health information technology has to be diffused. The trends toward employment for physicians is become a bullish force in terms of how we're restructuring healthcare. And then just the move toward population-based, and need to move toward more population-based monitoring of improving health. So improving health and healthcare is critical. I would look at the Affordable Care Act, which does so many good things, and Liz enumerated them about, the high-risk pools, the donut hole, the prevention issues, the under 26 coverage, the exchanges, the insurance reforms, the commitment to access. These are, I don't think we're going to turn, the commitment to access is a bit of a question with the Supremes. But the rest of those things that are out there right now, I don't think we're going to take those away or turn those back. It's amazing, though, to me, in so many presentations, how many people who are receiving some of those benefits don't seem to know it came out of the Affordable Care Act. Or how many physicians don't realize the people that are coming in the high-risk pool population, for example, that they wouldn't have been compensated for. Now they're getting compensated for. And they just don't get it that it's part of the Affordable Care Act. So, I think there's so much confusion that we've got to deal with, and we have a relatively short time to do that, actually, leading up to the elections. Because physicians are as confused as the public, as you all well know. And so, we do need to celebrate this law and celebrate the progress it makes and make sure that it remains. We also can amend it and augment it. Medicare's been amended every year. Medicaid's been amended every year. Nothing's perfect in law. And so we can talk to our colleagues who are hung up about some element of this and talk about how we can take what we've made here as progress, and then we can amend and augment. Because within the law, there are some aspirations that we all share. One of the aspirations is, in addition to expanding access, obviously, is to systematically improve quality of care, right? Isn't that something we all care about here? Now, the law doesn't actually guarantee that. There's still more to be done before we're going to accomplish that. There's some great things in there that attempt to go there. The accountable care organizations, the CMMI grants. Yes, there's a lot in there. But is that going to guarantee that we succeed in that regard? No, not until we consider to do more, that's part of our responsibility. Is it guaranteed that the Affordable Care Act will solve the cost problems in healthcare? No, it's not. It makes progress, but it doesn't guarantee. It's better than the status quo. But there's still more we have to do there. to become more efficient and effective in healthcare. That's true. And does it, it says, it aspires to resuscitate, if you will, primary care. And is it guaranteed to do that? Are medical students going to flood to primary care slots in the future? That's still not guaranteed, but there's a lot in there to help us move in that direction. Even though the guarantees, we still have work to do, is what I'm saying. There's more beyond the Affordable Care Act for all of us. Now, I was in Hawaii, and I was fortunate enough to be in kind of this magic moment where the stars aligned, and we took this employer mandate law, which had been tied up in the courts forever, all the way to the Supreme Court, tossed out, got Congress by about 2 votes margin to overcome ERISA and allow the law to go forward. What a fun, exciting thing to expand coverage, and even to do another law to get the self-employed, the part-time employed, the students and others covered. At one point, Hawaii got up to 97%. Some of those things eroded over time. But what an exciting moment for me. In California, when Gray Davis was governor, the California Medical Association got an unlikely alliance with SEIU and labor and asked me. And we got a Hawaii-like law passed there. Gray Davis signed it. Arnold Schwarzenegger led a campaign, a public ballot initiative, to overturn that law just before it was implemented. I then worked with Arnold too, to try to get him to move on his version of it, which was pretty much similar to what was going on in Massachusetts. Although he just didn't have the clout with his own party nor with the Democratic Party of Congress to make it happen. But I've seen things like this happen in my life, and I know that we can make this go forward. We can fix it, we can improve it. And from the cardiology vantage point, 43% of Medicare costs are cardiovascular in total. And if a 10% reduction in projected costs over the next decade in just the cardiovascular spectrum would, by my back of the napkin estimate, save over $300 billion in terms of how fast these costs are going to go up with the pipeline of obesity and diabetes and so forth, and all the new things we can do. That's like enough to pay off the current SGR deficit. And you know what? It isn't going to be. It's not rocket science. So Harold, we don't need you for that one. We can come up with 10% in projected spending in terms of and get there, and other specialties can too. So our challenge is in front of us in these areas, and it's the quality of care accountability is really huge. Every summer, I love to take a hike in the Sierras. I've done this with some medical student friends of mine. And very few years have we missed all the way through our careers and lives. And we take a week, no cell phones, no communication to the outside, backpack, 60 pounds, head way into the wilderness, and spend the whole week just in nature. And it's an amazing thing. As I get older, it's a little tougher to climb those mountains and do all that stuff. We take a little trowel with us today to bury the first person who dies out there. We're not going to bring anybody back out. But I want to just leave you with a message sort of related to that. And that's that it's a story. It's about who will save us and what's our purpose for being here with DFA. And the story is about a man who was climbing a mountain. And typically when you get to the top of most of these peaks, I've learned that what it looks like is an easy walk until you get up there in many cases. And then, there's a very nasty little last part. And so this guy was walking on this narrow spine with thousands of feet of drop on either side. And he was looking at the summit right ahead, and he said to himself, this is so amazing. Who am I? What is this all about? What is my purpose? He was having an existential moment, but he wasn't watching carefully where he was stepping. He slipped, he started to fall, and he would have fallen to a certain death. Except that he grabbed onto a root and he was just dangling in the air. Looking up, expecting nothing, he yelled out, is anybody up there? Will anybody save me? Anybody up there? Of course he thought nothing would happen. But to his amazement, this soothing voice spoke to him and said, I am here for you, my son. Let go of the root and you'll be saved. The man's eyes opened wide. He looked up. He said, is there anybody else up there? And so what I would say to all of you, is, it's it's not like who's going to save us as the profession. We have to save ourselves. Patients care about us, but they're not empowered to save us. We've got to come together in a new way, and we do need management skills. We do need leadership skills. We do need to see a bigger picture. We have to add some time to that. We have to get involved in advocacy, not just in the doctor's lounge, but getting out and giving talks to people, reaching out to the community, doing what DFA is asking this group to do. Telling our physician friends that the status quo is going to hurt healthcare, it's going to hurt their practice, and helping them understand that. We can't let the status quo move forward and prevail. We've got to support the ACA. We've got to find ways to amend what needs to be amended and augment what isn't included. And then we have to understand, as Harold said at the beginning of this, that it's a moral issue. But you know what? It's also an economic issue, an economic imperative. So let's make it happen. Let's make this group 10 times bigger and then 10 times bigger until that really occurs. Thank you very much.
Thank you, Jack. So now we have a good amount of time left for questions. So if people have questions, please raise your hand. There are mics going around the room. I have a question in the back corner. Is there someone in the back of the mic? Go ahead in the back.
Can you hear me?
Mic comes in here.
Thank you. Those are all great presentations. Since you brought up SPR, it's sort of the elephant in the room often when you have physician get-togethers with physicians and talk about healthcare reform. MedPAC, to its great credit, recently made a recommendation that rather than continuing to try to increase reimbursement for everybody, at some point we have to make the case that special reimbursement is out of proportion to primary care reimbursement. And every year we do this go around with the SDR fix and we say, oh, well, we're going to raise everybody's income a little bit. At some point, in order to correct the workforce problems in medicine and to encourage more people into primary care, don't we actually have to get to the point where we say there has to be a top limit for specialty physicians so that they're not making 4, 5, 6 times what